In triple negative breast cancer, we have seen that the benefits of checkpoint inhibitors as monotherapy is really quite modest. So, in looking at Keynote 86, we saw only about a 5% objective response rate in the second line and beyond, regardless of PD-L1 status. And then more recently in Keynote 119, chemotherapy was compared to pembrolizumab monotherapy, where pembrolizumab was not found to be superior to chemotherapy in the overall population. And so you think what we're seeing is that checkpoint inhibitors alone do have modest benefit. And there does seem to be greater benefit for checkpoint inhibitor monotherapy in the first line setting in a PD-L1 positive patient, where we saw in Keynote 86 response rates of around 23% in that population. And potentially in those patients with high PD-L1 expression, checkpoint inhibition as monotherapy potentially could be performing better than chemotherapy. If you look at Keynote 119 in those patients who had a CPS greater than 20, you did start to see the curve separate, favoring the pembrolizumab over the chemotherapy at that point. But currently, I don't think there's much of a role for checkpoint inhibitors alone until we're able to find an optimal biomarker to select patients for that. And we do see data clearly showing that benefit with chemotherapy and checkpoint inhibition is much more robust, as we've seen from Impassion 130, where we're now seeing a survival benefit from the addition of checkpoint inhibition to chemotherapy. So currently, the only biomarker we really have to select patients for checkpoint inhibition with chemotherapy in metastatic triple negative disease is PD-L1. So that is the only biomarker that we have to help us select patients. And really, that would be using SP142 for testing for PD-L1. I do think there are lots of other biomarkers that are being explored and that will need further work. We do have seen data from both Keynote 86 and Keynote 119 that responses were higher in those patients who had higher tumor infiltrating lymphocytes. So, certainly that does seem to potentially be a biomarker to help predict benefit to checkpoint inhibition alone. And there's some very interesting newer data that's come out about tumor mutation burden, where there was some preliminary data from a retrospective analysis of patients who had received either checkpoint inhibition alone or checkpoint with chemotherapy, where patients with high TMB, defined as greater than 10, did seem to have better overall survival relative to patients who had low TMB, and this was irrespective of PD-L1 status. So I think, again, we still have a long way to go to develop optimal biomarkers for prediction of checkpoint inhibition. But as of today, the only biomarker we have to predict benefit is PD-L1.